We're going to cover the prenatal and infant life next, and I hope you don't feel like you're being fed out of a fire hose. I know I'm covering a lot of information. I'm covering it quickly. Hopefully, you can go back and review and replay the tape if you don't get it. But this is a very important. These are very important periods of life and very important to our country and our tradition of being Americans, where mothers and infants are valued. What I'd like to do is I'd like to cover the following rates with you: infant, neonatal, maternal, mortality rates, and these are very important to us because they indicate the health and the wealth of a community or nation. And you would expect that the United States would be first in having the lowest rates in terms of infant, neonatal, and maternal mortality, which isn't the case. And I'm not going to get into those factors, but we should theoretically be one of the richest. We theoretically, actually, we are one of the richest nations of all time, depending on the metric used. But so you would expect us to have the lowest rates in these areas. Now, also factors that influence these rates are a poor economy, and when we have a poor economy, we have less people that come to this country, and we have fewer children that are born, and subsequently, what happens if we have an unemployment rate that is above 5 generally, and sometimes seasonally as high as 17, um, or it's protracted, it's 5 years or more, we have less children born, as I've mentioned previously. So there's other dimensions that seem to have some bearing on the number of children that are born, which also has effect on death rates. So there's a correlation there. Now, I'd like to make you more acquainted with this particular chart, and we borrow epidemiology borrows from all disciplines, and this chart comes from child and maternal health. Um, and in public health, we have a division or a special division called child and maternal health, and this is information that would be basic to them and maybe basic to you. But I want to just focus on this graphic here for a minute or figure, and I want to talk about the prenatal period, and I want to talk about the infancy period, and I want to talk about the length of time of each of these. And if you were going to tell me the length of time of the prenatal period, it would involve 20 weeks, and 20 weeks or 40 weeks, and it would include the early fetal period and the late fetal period. Now, I'm showing conception here, but we'll come back and talk about that. Then, if I was going to talk about the length of the infancy period, we would talk about the postnatal period, which involves 48 weeks, and the neonatal period that talks about 4 weeks for 52 weeks. Now, generally, when we talk about the neonatal period, we think about it being 28 days. So don't lose that thought. It's not 30 days. It's not 31 days. It's 28 days. So if I was going to ask you about the perinatal period and its length, the perinatal period is 20 weeks and 4 weeks, or 24 weeks, and it involves both the late fetal period and the neonatal period. Now, let me ask a couple of other questions because I think these are important considerations as well. First off, when do we issue a death certificate in the state of Indiana? Well, we issue it in the first 19 weeks. Okay? So the death certificate is required in in the first 19 weeks. So 19 it's a period of intrauterine fetal development from conception to birth, but it's issued. If a baby dies in 19 weeks, we provide a death certificate. Um, Now, I'd like to ask you um, when we have the greatest number of deaths of infants, and the greatest number of deaths occur within the first 28 days of life during the neonatal period. But more specifically, the greatest number of deaths occur in the first week. And so during this first week, the first day is the apex. That's the highest number of deaths that occur, and then they drop off in the first 7 days, but they do continue for this 28-day period. Okay, I've covered all of these, and you can go back and check them and check yourself and make certain that you know them. Um, Formulas utilize this information. Data is reported by the federal government according to these periods, and I want you to see them um, as we go along. And I've covered when most deaths occur and what the Indiana standard is. Make certain that you understood what I was talking about in terms of when we issue a death certificate in Indiana, and this does vary by state. So, but you can see it's at the 19th week until birth, and after birth and during the 28 days or any time in the first year. So, and we, by definition, gestation is a period of intrauterine fetal development from conception to birth. So, if the baby takes a breath, it's considered a viable birth, and a birth certificate is filed. On the same or the next day, both a birth and a death certificate may be filed. I'd like to talk to you about all those periods that we covered on that chart from child and maternal health. And I'd like you to see that we have, and you will recall the infancy period, and we know that to be a year. And then we have under 28 days, or the neonatal period. And I talked to you about the first 7 days of life and why we focus on that. And then the postnatal period, which is the 48 weeks of life in the first year. And the late fetal mortality period, which is 20 weeks and right before birth. And then the perinatal mortality period, which is 24 weeks. Now, notice that things are divided. And if I was asking for the crude rate versus the specific rate, what would you tell me would be the crude rate? Well, the crude rate would be all races, and the specific rate would be according to color. So the specific rate generally provides more information, but not every country has demographic variables, which we can provide more information as we can in the United States. And I want you just to notice a trend in infant mortality within the U.S. When we go from 1950 to 1980, you can see that the infant mortality was 29.2 and it dropped to 12.6. And you can see that all of these are dropping all the way across. Okay, there isn't an exception to that. Now, when we look at whites, or Caucasians, or whatever word you want to choose to describe the difference between these two racial groups, you can see that these values are more similar to the nation, and these values are much higher. And that happens across the board, okay, in every one of these categories. The line just means that we have missing data and we can't provide it. Now, the current topic, one of the current and attractive topics that's being researched a lot these days, has to do with health disparities. This graphic gives you an idea as to why we want to focus on health disparities, and we want to have different prevention, protection, and control mechanisms in place. Remember, public health can't focus on every population, so we have to, if you will, target or identify those with the greatest needs so we can address those to see whether we can't reverse the trends in those given areas. Gestational age, you all know about this. It's measured from the last normal menstrual period. When the period stops, gestation starts. These are key definitions that are utilized that have to do with gestation. Oftentimes, new mothers don't realize that the baby is expected in we talk about 9 months, but it's actually a little over 9 months, and that would be preterm. And so when we bring a baby to full term, you can see again, my point is that it's greater than 9 months. In post term, the baby has been in the womb, probably some women would say too long. And this is not particularly desirable. We do, if you go to Indianapolis and you go to the lower socioeconomic status neighborhoods, you'll find that the women, the girls, girls or babies or kids having kids, if you will, that they learn very quickly how to reduce the size of the infant so that it's not as painful, and that's by tobacco and alcohol. So just interesting information about what goes on in terms of childbirth and important information to know about between preterm, term, post-term, and gestation. Now this graph shows a decline in maternal mortality rates, okay, from the end of World War II to 1970. And but I really want you to focus on other factors, and we're looking for the reasons for the decline. What is the crude rate? What is the specific rate? What is the difference in the information you can get from these two? And what subgroups add most to the crude rate? Well, what we did the answer, the reasons for the decline, as we began to focus on mother's health to include eating and exercise habits, um, transportation and access to clinics, nurseries at clinics that provide free child care, um, or teaching mothers about issues related to puerperal causes of death and well baby visits, hotlines for expectant mothers to call, advances in medicine, and you can probably think of other factors as well as to why that began to decline, because the death rates per 100,000 were pretty staggering. Now, what is the crude rate? Well, that's the total, and you can see it underlined in purple, and it's a dark line in it, and you can see how it drops over time. Now, what is the specific rate? We're looking again, not in a table, but in a figure, between non-white and white. And the specific rate tells us that we have uh, crude death rates occurring more amongst non-whites than whites. And so that tells us, if you will, which is a preferred population that we need to be focusing on in order to have a significant difference and decline in death rates. So, what subgroup adds most to the crude death rate? That's the non white population, and that should be the one of focus, again, because we can only focus on those populations or subpopulations with the greatest need. And I'd like to talk about infant mortality rate, and we mentioned previously that that was within the first year of life. Okay, so that's the number of deaths in a year of children under 1 year old. So we're looking at from day 1 to 365 days. And it has to do with the number of live births during the same period. And again, I mentioned that a year can vary depending on whether it's a leap year or not. Okay, so this is one of our two main organizing categories, is infant, and we talked about the prenatal period before. Now, what was the number of infant deaths in 1980? I'm going to bring a heuristic problem to your attention in just a minute. What was the number of births in 1980? What are the number of births and deaths both occurring in 1980? What is the infancy mortality rate for 1980? And is infant mortality rate a true rate? Okay, let's look at. We're going to be looking at a period that's going to begin in 1980. So we're looking at January through December. And if we are focusing on the infant mortality rate, we're going to look at our information in the table that talks about infant deaths. So if we're going to only be counting in 1980, we're not going to be counting in 1979, we're not be counting in 1981. So how many infant deaths do we have in 1980? Now this problem's a little tricky, so I want you to stay with me. So if we were going to count, case number 1 doesn't apply. Case number 2, here's the case numbers over here, doesn't apply. Case number 3 doesn't apply, but there's an infant death with case number 4, so that's 1. And case number 5, that's 2, that's within this year period. And case number 7, that's 3. And case number 8, that is 4. And case number 9 is outside of the period, so we don't count that one. And then we count case 10, I think that's 6, 7, 8, and 9. Now, should let me see, I think there's only 8. Real quickly, 1, 2, 3, 4, 5, 6, 7, 8. There are 8 infant deaths within the year 1980, the annual period, and now that's the numerator. The denominator is the number of live births, right? And so we're going to look at number of live births. So how many live births do we have? Okay, live births is a B during this time frame. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9 live births. Now, is that all the live births? No, it's not. Other live births not shown in this graphic are 191. So 9 that we counted up here plus 199 makes that 200. So if we were going to look at the infant mortality rate, we would let's look at our formula. I think let me go back to the formula. The number of deaths in the year under 1 year is, how many did we have? We had 9. Number of live deaths during the same year, we had 200 and times 1,000. So the infant mortality rate for 1980 is 40 per 1,000. Okay, so now the next question, okay, and you see how I figured that, and you can go back and review that again if you are confused about it, is whether or not something is a true rate. How do we determine whether something is a true rate? Well, you have to consider the same cases in both the numerator and the denominator. And I'll go back and show you this, that we did not do that. So sometimes we take into account a case in the numerator, but not in the denominator. And I want to show you case 13 is taken into account in the numerator, but not in the denominator. Cases 2 and 9 were included in the denominator, but not in the numerator, and was demonstrated the numerator is not totally a subset of the denominator. And of course, in order to meet our definition, it would have to be. So IMR in this particular case is not a true rate. So let's go back just a minute for heuristic purposes and look at these particular cases. So if you take case 13, we took part of the information from case 13 in that we looked at the infant death, but the birth was outside of the time frame. And so in regards to births, for it to be a true rate, the birth would have had to occur here and the infant death would have had to occur in the same year. If we look at cases 2 and 9, we can see that the birth occurred during the 1980 time frame, but the infant death was outside of what we would have expected. And the same is the case for case number 9. So in case number 13, it's not taken into account in regards to the numerator, And um, uh, I mean, it is taken into account in regards to the numerator, but not the denominator. In cases 2 and 9, they were included in the denominator. 2 and 9 were taken into account in case of the denominator, but not in the numerator. So for IMR to be considered to be a true rate, you cases must be all cases must be considered in both the numerator and the denominator to be a true rate. Okay. Now, ways to reduce infant mortality. One of the things we're always focusing on and concerned about is adequate prenatal care. And as I mentioned to you, the in ethnographic studies of the youth of Indianapolis, they found that the birth weight was affected, and they could have smaller infants, and if they were children having children, that alcohol, smoking, and other drugs reduced the weight of the baby by um, a significant amount. But so we are wanting mothers to not engage in those kind of behaviors. We want them to reduce chemical exposures. We want mothers to follow an immunization program, and we're finding out that there's a reduction of mothers doing so. There's all kinds of misbeliefs and misconceptions about the number that become ill as a result of immunizations. We talk about proper sanitation and infection control, and we know often that homes and the way babies are treated and housed, the environment simply is not hygienic. And adequate nutrition. Adequate nutrition is very important, and I already talked about proper hygiene of the parent and the baby, and treating that baby so they are protected from an infectious environment or situation or home. Now I want to talk about neonatal mortality. And remember, when we were looking at neonatal mortality, we were focusing on the first 28 days or the first 4 weeks of life, and we talked about this as being a very critical or vital period. So that is important to us, and we should um, pay special attention to an infant during that time frame. So we're looking at, when we talk about neonatal mortality, we're talking about 28 days. And even so, it says under 1 month. But again, as I pointed out before, it's not 30 days, it's not 31 days, it's 28 days. And we're talking about the number of live births. And I want you to notice that the formulas are identical in terms of the denominator, because the denominator is a number of live births. The only thing that's changed in these last two formulas is the numerator. We talked about just a second ago, I know that the maternal mortality and the neonatal mortality rate are the same in terms of the denominator. They differ in terms of the numerator. And you'll find when we get to maternal mortality rate that the denominator is the same again, it's number of live births. So all you have changing is the numerator, and the constant will change with maternal mortality. But let me get back to where we were. I just want to try and summarize as we go along as much as possible so you're tracking with me. And now, if we look at neonatal mortality, NMR, as it's referred to, we're looking at a 28-day period between birth and infant death. And I'd like to go through and count these with you so you're right with me in terms of how we would actually calculate this. So if we look at case 1 and we look at the legend down here, case 1 doesn't qualify. Case 2 doesn't qualify. The baby was born in February and died outside the period of interest, which is 1980. Case 3 doesn't qualify either. Case 4 does. It qualifies in that the baby was born and died within 28 days. Case 5 doesn't qualify. Case 6 doesn't qualify. Case 7, too long a distance, it doesn't qualify. Case 8, it does qualify. And case, where am I? Case 9 doesn't qualify because too far apart and outside the parameters that we're looking at. Case 10 doesn't qualify, and case 11 does qualify. And case 13, although close, doesn't qualify, and none of the rest of them do. So in summary, you have cases 4, 8, and 11 that qualify. And then when we look at the births, we already counted those before, and there were 9, and we added them to the 191, and we had 200, so the rate would be 3 divided by 200 times 1,000, which would be 15 per 1,000. So if we're looking at that and we're talking about it and trying to translate it into practical terms, we have, after doing some division, we have 15 divided by 40, or 37% dying within the last 28 days of life. 15 is a neonatal mortality, and 40 is infant mortality. So I just took those two and divided them, and that's how I came up with the 37%. So about 1/3 are dying within that 28-day period. So you can see that that's a high number. And the reason I can do that division between the infant mortality and the neonatal mortality is because they both have the same K, or the same constant of 1,000. So that's why that's possible. Now, you might say, well, okay, we have the data, now what are we going to do with it? Well, intervention or baby visits may become very important. So during that time frame, there can be an intervention and problems can be detected early, and that would lead us toward primary prevention, of course, and that's what we always hope is going to happen, because that's usually the least expensive and the most effective. So especially during the prenatal and the neonatal period, these baby visits are very important in terms of life expectancy and whether the baby lives or not. Now, let me go on here because I want to talk about we're always always getting to something that we can do. That's what the purpose of epidemiology is. It's going to identify a problem. We're going to get a statistic, and then we got to think of an intervention. And our interventions are in increasing tenfold all the time, because what we're doing at this stage in epidemiology is combining um, a lot of various methods with new technology, and it's being developed all the time, and that really helps us in terms of how to communicate how to communicate with people. We can see that there's going to be a huge explosion in the combination of technology and new technology, so that it's going to be real-time communication. But anyway, let me get back to the case at hand. So um, we calculated as follows. We took the neonatal mortality rate for 1980, and you need to know that. And then we did this division process with infant mortality, and we saw that in this particular case that had we divided 15 by 40 to come out with 37%, or nearly a third of the infants dying within the first 28 days. Is NMR a true rate? Well, yes, it is a true rate, because the birth and the death are linked. Is there a case where it might not be? I can't think of a single one. You can just see that it's impossible to separate the two. So NMR is a true rate, and it's not possible that, because the birth and the death have to occur within the same year and the same time period in order to be counted. Yes, NMR is a true rate, and there's not an instance that I can think of that it would not be, because the births that we use for the denominator are all counted within the year, and the numerator, we're looking at a birth and a death within 28 days. Okay, going on. These are things that usually that we're interested in terms of neonatal mortality rates and what we can do. Low birth weight is the number one cause, and we talked about reasons for low birth weight, and often that's children having children, and they know every means to keep that infant as small as possible, to weigh as little as possible, and poor prenatal care if they get it at all. And so that's another major issue, and I know you all are aware of these things. Infections. Oftentimes people are not in clean environments, and don't understand the spread of infection, and don't understand the importance of washing their hands. That's a real effective means, and follows Occam's razor of parsimony, and doesn't cost much. And the lack of proper medical care at the right time or during the course of the pregnancy, and injuries. We know plenty about injuries. We hear it on television, and injuries can be those that are self-inflicted or inflicted by others. And prematurity is an issue as well. And congenital birth defects. Oftentimes we have people that are having children that already have problems themselves, and so that's a problem. and functional health literacy and poverty. And um, um, there's a greater likelihood of difficulties there, because if you can't read health information and understand it, and you come from an impoverished situation, your likelihood of getting help is less, and the likelihood of death is greater. Um, Former Surgeon General Richard Carmona had as his first priority functional health literacy. He saw that was so important. He was a common denominator for the problems listed above. And the current Surgeon General, Regina Benjamin, her top priority among youth is bullying in the schools, and you can see that related to injury. Um, so, but a lot of these issues were elevated by C. Everett Koop and Joyce Elders. So these were all significant surgeon generals that brought these problems to our attention, or tried to bring them to the attention of the public. And of course, the reason they're called surgeon generals is, in fact, that they all hold the rank of a general officer, a 4-star general officer. We talked about the conclusion and how we got it. About 1/3 of all infant deaths occurring during the neonatal period. We use two formulas and divided one by the other, and the reason we can do it is because we have the same constant. In this case, it was 1,000. And we looked into preventive strategies. We thought about preventive strategies, and we know we need to focus especially on the prenatal period, and then the postnatal care, the time period immediately before and after pregnancy as well. And we need to have health education for mothers, and changes in policies pertaining to access, and this is happening under Obamacare, and changes in laws that make some behaviors mandatory in terms of infants, and what needs to be done with them in terms of their care. Now, I mention all these things. I talk about laws and policies, but there's just, as you know, in healthcare, there's a lot of things people are not going to do, no matter whether you make it a policy or a law. And we know that the policies are different than laws. Laws are congressional. Policies are usually set by institutions or companies, and sometimes they coincide with laws, and sometimes they don't. But the primary thing I'm trying to get to is compliance, and people don't comply, obviously, with medical instruction, and even with medical instruction that would be life-saving and wouldn't cost so much or require much effort. So I want to talk about maternal mortality. And notice here again we see the ratio. The word ratio pops up, and the constant is different. We have 10,000 rather than 1,000 in the prior two formulas. So this has to do with the number of deaths from pregnancy or childbirth. Okay, and as I mentioned before, the infant mortality, neonatal mortality, and maternal mortality all have the same denominator. So if you learn one, you learn them all. Now, the K changes, and only in this particular case of maternal mortality does it change to 10,000. I'd like to take you through and have you count maternal mortality with me. Now, what we're looking at is the MDs. Okay, so we're going to go together and look at MDs. So case number 1 would apply, and case 2 doesn't, case 3 doesn't, case 4 doesn't, case 5 does, case 6 doesn't, case 7 doesn't, 8, and the rest of them do not comply. So we have 2 maternal deaths out of 200 births. So if you multiply, if you do the division, you for maternal mortality, you have 2 divided by 200 times 10,000, or 100 per 10,000. And this is normally what we see, is that we have fewer maternal deaths than we do infant deaths. It doesn't mean both can't happen, but generally you're going to find that an infant's going to die far more likely than a mother. So the fetal death period means the death occurred during the prenatal period, which is made up of the early and late fetal periods. We talked about that. They can die during that time frame, or they can die after birth. So, and the greatest risk is with the firstborn. Even though risk drops off, it does not become non-existent the more children that you have. Let me continue about maternal mortality. We've calculated it, and we've drawn conclusions, and we've talked about, well, I'm going to show you the calculations, and then we're going to draw conclusions again, and what prevention strategies could be used, and would you focus on mothers or infants? And we've really covered who we would focus on already. But if you were going to do it, you can see what we've done. We've counted 2. We have 200 live births. Here's our calculations, and this is what I've shared with you earlier. And as I go on, we count any death connected to pregnancy, not just deaths connected to childbirth. So I want you to separate this at birth. So you count those deaths prior to or during the pregnancy period, and then you count those deaths related to childbirth. So separate that out in your mind and see it as 2 distinct periods, and you might even want to see it along a continuum where a child can cause death to a mother. Okay? Deaths in the numerator are deaths arising from pregnancy, are from puerperal causes within 42 days, 90 days, or even up to 1 year after childbirth. Okay, and we mean by puerperal anything related to or that exacerbates a problem that a mother already has. So let's say a mother has high blood pressure. If that high blood pressure is exacerbated by the carrying of a child and the mother dies from that, even after the baby is born, it's considered a maternal mortality. So now you say, well, what is all this mumbo jumbo about the various days? Why do we have the various days? Well, different organizations note these or utilize these days. The WHO standard is 42 days, and I mentioned the puerperium before, pertaining to or caused by a related child birth, and gave you a definition of that. Now, we tend to use the WHO standard, and that's why I concentrate on it here. And because the further away you get from the baby being born, the more difficult it is to make a case that the baby caused the death of the mother. But we just, different standards are used, but 42 is the standard that is used most often. Let's see if there's anything else I ought to be telling you that I haven't already. I think we're right on track. Um, um, so Okay, I'd like to take a moment here and just compare and contrast the formulas for neonatal mortality and maternal mortality. And I've said this before, but I wanted you to see it on a diagram. We got the same denominator. The difference is the K's. One's 1,000 with moms, it's 10,000. And any time the K becomes larger, like 10,000, that means we have fewer deaths. If it becomes 1,000, that means we have more deaths. If it becomes 1,000,000, that means that's a very rare circumstance where we have deaths. So the K gives you an idea about the frequency occurrence of deaths. So if you have 1,000,000, you have very few. If you have 100,000, you have more. If you have 10,000, you have a greater number of deaths. If you have 1,000, you have a greater number of deaths. So what's the difference between the two formulas, between neonatal? You're comparing infants in both the numerator and the denominator, and with the maternal, you're comparing deaths of mothers in the numerator with live births of infants in the denominator. Okay? So that should help you come to understand these formulas and not have to do so much memorization, and you should also be able to understand the K a lot easier. Okay, now let me talk about maternal deaths, and I told you that they were subdivided, but they're subdivided in another way as well. They're subdivided in the terms of direct obstetric deaths and indirect obstetric deaths. And with the direct, it's a result or a complication during the pregnant state. Okay, so that's while the mother is carrying the child, and might be this is an example: the death of the mother due to surgery to remove a diseased or stillborn child. Indirect obstetric deaths are those I talked about where the mother may have high blood pressure, diabetes, or something like that, and this condition is exacerbated by being pregnant, and therefore a death of the mother might result. Okay, examples of puerperal causes related to deaths or ruptured uterus, puerperal fever, running high fever during pregnancy, stroke due to baby, carrying the young in the uterus, hypertension, cardiovascular disease, stroke, and diabetes. So these are all the indirect ones that I talked about before. Now, Semmelweis, you remember me talking about him during the history section, was called the savior of mothers after he discovered the power and benefit of hand washing, that it prevented puerperal fever. So I keep talking to you repeatedly about hand washing and its value in trying to connect this to everything that we've talked about, many things that we've talked about thus far, and especially the spread of infection. And we have the spread of infection in hospitals and elsewhere. In some places, and hospitals are ranked according to the spread of infection. Weaknesses of maternal mortality rate. The denominator does not exclude all pregnancies that do not result in live births. So it doesn't take into account stillborns, induced abortions, miscarriage, ectoscopic pregnancies, and you know about those, a complication of pregnancy in which the embryo implants outside the uterine cavity. Okay. Public health officials still debate how long after delivery a maternal death can be attributed to childbirth. So is it 42 days? Is it 90 days? Is it 1 year? All those standards are used, but the preferred one is 42 days. Okay, this is just a chart from California, and I'd like to run through it with you rather briefly, but I want to show you. The point is the statistics and the rates that we're going over are common. Here's crude birth rate. We didn't talk about teenage birth rate. We didn't talk about cesarean births, but we sure talked about maternal mortality rate. And we didn't talk about percent low birth rates, but we are talking about infant death rate, crude death rate. So these rates that we're reviewing are in government tables, and that you need to know about them, and they talk to you about how they're calculated and whatnot. So I'm trying to make that very clear to you, so you realize that we're learning rates that are valuable and useful. Now, when we look at, let's take one, how they're compared. We're looking for trends. Anytime we're using a rate, we're looking for trends. And this is the U.S. trend, and that's the best indicator, or the U.S. value, which would be a median of crude birth rate. And so what we always do is we compare the values that we have, these medians from prior years, to the current median. And you can see that for California, they're worse off than the national median. And with teenage birth rates, you can see that they're still slightly worse off. Okay? And you can go through these yourselves, and you can see they do pretty well here. But the percent of mothers with first trimester prenatal care, it's still not 100%. It's better. So I always look to see how it compares as a number by itself, and then how it compares to 100. Are we reaching? And I don't know. It brings into question whether we are reaching the most important audience. Are we bringing into the clinic those that most deserve to be there, that where we're going to have some type of infant death? And percent cesarean births, and I find this interesting. Look at this. In 1970 it was 6.9, and it rose, it more than doubled in 1980, and you can see it's still on the increase. And that brings up a real interesting question as to why we're increasing the number of cesarean deaths. Births. Maternal mortality, you can see that is declining, and California in 1985 is a little better than the nation. Low birth weight, California isn't too much better. In fact, it's a little worse than the nation. Life expectancies, these are changing, but they're not changing at the rate that we would anticipate as being as a result of being one of the richest nations. Infant death rate, you can see what's going on here. They're having a drop, and they're slightly better than the nation. Crude death rate, you can see a slight drop, and then maintenance, but better than the nation. And heart disease, and you can go through these yourself. But let's just summarize this together so you can, because I want you to get used to analyzing charts, and I want you to get used to looking at legends. And I want you to see that the things that we're talking about are routine statistics, and you need to be able to interpret those statistics for yourself. You don't want to rely on others to provide you information. This information is available, and you can get all kinds of information from the Centers from Disease Control. Of course, central headquarters for the Centers of Disease Control is Atlanta, but the closest one is in Chicago. And oftentimes, if you're in a particular catchment area, small area, you can call an 800 number for CDC and ask them to send data that particularly pertains to your area of where you're operating. Okay, let's just look at these together, and this is just conclusions that I have drawn and gone over with you, so you can see whether your analysis agrees with mine and how I came up with the conclusions that I did. And what are your priorities or hypotheses? What would you focus on? These data, that's the purpose of these data. I mean, they really ought to guide you in this respect. What methods might you use in these particular cases? If we have health education, health promotion, we have policies and laws. Well, maybe policies and laws would be a way to go. And I'm not convinced that that's the total answer. That's one answer. So one of the things I think that we would need to do is we would need to focus on mothers, especially in the first trimesters. And the fact that we got women far outliving men is another issue. And we've got a new area now that we call men's health. I think that's interesting. We've had women's health for years, and now we have a new area that's receiving a lot of focus, and that's men's health. So those are priorities. You can see in California that they ought to be focusing on unintentional injury, suicide, and homicide. We looked at those graphics together in terms of the leading cause of death being unintentional injuries from 1 to 44, so you can understand that and how that fits in, and that might be further justification. That might even be a reason for a grant or doing something of that nature. And I'm certain in the state of Indiana or whatever state that you are in, especially in the Midwest, we are leading the way in many negative health areas. So there's plenty of room for improvement. Now, the question I would ask you are your political representatives addressing these issues. Are we seeing adequate progress? Are we seeing the progress that we should be seeing as a result of being one of the richest nations of all time? And oftentimes policies and laws are made because of 5 handwritten letters to a congressman. So I don't know that people, our country leaders, are aware of these data. If they are aware of these data, I don't know that they're paying attention to them. And so I think it's very important for those interested in healthcare and public health because I don't know whether you won't be a future leader. And if you're a future leader, where will you go to collect data? I hope you're going to be using the secondary data sets that I'm going to be talking about here in the future. I think we need to be data driven. Um, we always try to get away from supposition in opinion. And the way to do that is to be driven by the data that's collected and that we have available to us. And as I mentioned to you before, we, the United States, is rich in data, all kinds of data available to be addressing some of these issues. And then you can set your own priorities, and there's ways to do it with Healthy People 2020. Surgeon General's already laid it out. So if you want to go chronic or acute disease, and my preference right now is leaning more toward acute disease because our world has become small and the control of communicable diseases manual is becoming thick, and we have a lot of problems that need to be addressed both at home and worldwide. I'd like to introduce you to some additional formulas. I know that you have gone through many already, but before doing that, I want to talk about your attack skills. So you don't get confused. You want to be able to um, write down the formula, and you need to know the abbreviation of that formula. Then you want to substitute in the numbers, do the calculations, and draw your conclusions. And I'm going to be introducing a formula to you that you're going to be using in the future with a more advanced type of statistic. Um, and so it's important that you have a good understanding of this at this juncture. And this formula is used to tell the prevalence of a prevalence rate of a specific disease among the population. And is it a crude rate? Yes, because it doesn't have any demographic information to break it down further. And this is what's used in Healthy People 2020 to list the diseases in priority. Now, I'd like to introduce you to a problem, and I want you to be very careful about looking at this problem because there's it's a little deceptive. And so I want you to study that table just for a minute. It's got a nice layout and whatnot. But if I was going to ask you to calculate the formula for the cause-specific death rate for leukemia, where would you focus your attention and why? Now, this is for leukemia, right? And we know that leukemia this is a crude death rate. So, with that in mind, then some of you have already jumped ahead and know what to do. So we would look at the total leukemia deaths in the population, okay? And the others are age-specific death rates. And this is a cause-specific death rate, and the cause is leukemia. So when we look at the cause, we looked at the total values, and we did the following calculations, and we came out with 250 cases of leukemia death per 100,000 population, which is our reference group. Now, our reference group, again, if I want to make certain I've made this clear all the way through, is a hypothetical group that maybe somebody could make reference to. And oftentimes we think of a football stadium. I guess the big house at the University of Michigan holds about 110,000. So, or we can think of a city that's about 100,000. So the cause-specific death rate of leukemia is the total. The age-specific death rate is listed here. And you can see that this runs in a linear fashion. We got 1,000 per 100,000, and we got 2,000 per 100,000, and we've got 5,000 per 100,000. So what conclusions would you draw about this? Well, leukemia doesn't seem to have a particularly profound killing, doesn't seem to be particularly profound in terms of the prioritizations of diseases, because we're using 100,000 and the number is not particularly very big. Remember now, if this was 2,500 per 10,000, this particular disease would be having quite an effect and would probably be moved up into priority. But what we're seeing with the age-specific information, and age is used first and then gender or sex is used second to draw conclusions, but with age you can see as you grow older there are more cases with leukemia per 100,000. So it increases almost in a linear effect, in a linear manner. So if we made this 3, it would be a perfect linear line. So we'd start out with 1,000, 3,000, and 5,000. It's not quite perfect, but it's not too far from it. Okay, now an age-specific calculation, it tells us about the pattern of the disease and what variables you may want to learn more about. In the last case, we used age, but there are other variables that we could concentrate on, and I mentioned sex, and there are other differences among groups that you might want to look at to further understand leukemia and its priority. You could look at socioeconomic status, educational level, health literacy, race. In other words, we're looking at the demographic factors again because they're the easiest, they're the most readily available, and often these factors alone provide a lot of information about the particular problem and who we're going to focus on, and then what type of strategy we might or intervention we might use to change the population in terms of this particular health problem. Whoops. The next is proportionate mortality rate, and I've always found this one to be very interesting. It's the number of deaths from a particular cause divided by the definition of all causes. And this shows, this gives us a little different information, and notice the K's. So this is indicating that the killing power it gives us an idea of the priority of the disease and how potent it is, and shows the ranking of the disease and their priority among diseases rather than their occurrence of the disease in the total population. So if you focus on that line, shows the ranking of diseases or their priority among diseases rather than their occurrence of the disease in the total population. Okay, so, and you notice the difference in K. Now I want to talk to you about a case fatality rate, and this is probably the one that you'll want to note the most, because especially if you have a family member who's undergoing a, a difficult disease like cancer, and you want to know what their prognosis is going to be. And this one shows the killing power of that particular disease in relationship to those who have the disease. I want to show you an example. The case fatality, this is deaths from a specific cause, and let's say that cause might be related to any disease, and there are 60,000 people who died of the 120 people who have the disease, and it's times 100, so you know that this disease is probably going to have quite an effect on death rate. In this particular case, we do the division, and we have 50 deaths per 100 cases, or 50% of those who have the disease will die from it. Okay, and this is information you're often trying to seek, and you can get this information from government tables. Usually physicians and others related to serious diseases are reluctant to talk about the case fatality rate. But some are very proud of them. If you're being treated for cancer, some of the cancer institutes report their case fatality rate, so you can tell your chances in regards to prognosis. I want to present you a real life problem. It's an estimate, but this is a case fatality rate and having to do with smoking. And this comes from Indiana, and we've looked at data and put it together for you. And based on Indiana, Indiana has approximately 21.2% of Hoosiers who smoke, and the state population, as close as we can figure, is 6,483,802 million people. And if you look at that, you take the percentage of the total population. There's 1,374,000 people 1,374,566 smokers in the state of Indiana. Now, if we're looking at the case fatality rate, we're looking at those who die of tobacco-related deaths over those who smoke. And as you can see, it comes out roughly, it's not quite one person per 100 individuals who smoke, but if you change it to 1,000, it comes out to 8.45 per 1,000 will die. So, which is not quite so we're looking at one. You could round it off and say one person out of 100 will die of a smoking-related disease. But that's one way to interpret the number, but that's not the only way to interpret the number. The number itself, the actual number, the 11,620 who die, is a phenomenal amount. Now, this is each year. This is annually. This is every year. This is the number that we're having die from tobacco-related, smoking-related illnesses. So if you look at that in terms of the number of people who are dying in Iraq and Afghanistan, this number in Indiana is roughly double that who are dying in a war zone. And these people are dying from the addiction of cigarette smoking. Now, what troubles me, and I hope troubles you, is that we're very quiet about this. We accept this as a standard. we anticipate that this is going to happen. I was reared in the Vietnam era, and of course, that was a very unpopular war, and we didn't like deaths. And there was a lot of commotion about the number of people who were dying. And now, don't misunderstand, we don't want to lose any lives due to war. Um, but in this particular case, we're losing approximately this many Hoosiers every year, and there's no clamor, there's no public health outcry, there's no um, seemingly disdainment for the fact that this number of people are dying. Now, you might say, well, hey, that's a self-inflicted disease. These people become addicted, and we know that mentholated cigarettes are more addictive than others, and they have done this to themselves. That might be an argument you would pose, and that might be a thought that you would have. Okay, but you still want your neighbors dying from something that they could curb if we had good interventions and good compliance to interventions, or if we could cut this number in half or in a third or something of that nature. That would be a significant contribution to society and to Indiana. Now notice too, I'm only mentioning one state. I'm just mentioning a state of about 6.5 million people, and we're losing this many people in our state. That doesn't count the surrounding states. I'm not looking at the other states. I'm not looking at the other 48 states and Hawaii and Puerto Rico and other places. So this is just in our state alone that we're losing this number. So you take that on an annual basis and look at all the states, you're losing a horrendous number of people annually to smoking and smoking-related deaths. And remember too, that what's happening is that our cigarettes are becoming more addictive, so it becomes more difficult to abstain from smoking. Of course, the best prevention is not having people smoke to begin with. We know that smoking is an addictive behavior that's hard to get people to stop, but maybe we need to be starting where the smoking stops. And I look at that in the grade schools, and probably the research shows that the most influential people in terms of a smoker are their peers, and what their peers do and their peer groups do seems to be what they do. Of course, it also makes a difference if their parents smoke too. So I leave you with those thoughts, and we're going to go through a quick review here of all the rates that you've learned thus far. Now, you remember that every one of these is a crude rate. Every one of them is an accrued rate. Now, you can take this, and I'd use it as a test, and I would just sit there and write out formulas. And I'd write out the constants along with it, because you know the formula isn't complete without a constant. And you know that all of these are crude rates because none of them include specific information related to demographics. Okay, so you've seen the table that we've shown you earlier, that where you can make a crude rate into a specific rate.